So continuing your lectures on trauma, we've had lectures on initial assessment and management of patients. We've had a lecture on airway, we've had a lecture on breathing and ventilation. The lecture on circulation, which is shock, has been taken by Dr. Ashir. Now we'll be talking about some specific injuries. Okay, so the first one that we have for you is thoracic trauma. So what is important in thoracic trauma? You have the thorax, which contains a lot of vital structures. It contains the heart, the great vessels, it contains the lungs. So injuries to the thorax can affect all the three components, which is A, B and C. It can affect the airway, which is the trachea and the tracheobronchial tree. It can affect the breathing, which can be caused by injuries to the, from outside to inside, can be affected by injuries to the rib cage, the pleura, to the lung, and then it can cause problems in C, which can be due to penetrate injuries to the, again, lungs and the pleura and cardiac and great vessels. So this will affect your C. So what is important in thoracic trauma is that because these structures are protected by your rib cage, any thoracic trauma will give you a clue that this patient underwent a very high force of injury. Okay, so the force which caused the injury was of a very high value. So because of this high force, these injuries can cause a lot of life-threatening problems. So these injuries have to be identified in the primary survey. That is why thoracic trauma is important. Thoracic injury is common in the polytrauma patient and can pose a lot of life-threatening problems if not promptly identified and managed in the primary survey. So how do you manage thoracic injuries? You follow the basic protocol, that is A, B, C, D, E. This protocol has to be followed in every trauma patient. Whatever you take back from these lectures, you have to imbibe this, okay? So you get a question on trauma, you get a patient on trauma, it has to be done in this way only. You look at the A, you look at the B, you look at the C, manage them, then go ahead. A, B, C, D, E. This protocol has to be followed in every trauma patient, okay? So thoracic injuries as well, they are no exception. You subject the patient to a primary survey, A, B, C, D, E. Identify problems in A, manage. Identify problems in B, manage. Identify problems in C, manage. And then you go on to secondary survey and definitive care. So what are we scared of in thoracic injuries? Hypoxia is the most serious aspect of chest injury. What is our goal? Our goal is to prevent and correct hypoxia. Okay, early correction and prevention of further hypoxia is our goal of primary survey and primary resuscitation. Okay, most life-threatening injuries, that's the good thing about thoracic trauma, that the management of thoracic trauma is very, very simple. You do not need complex knowledge to manage thoracic trauma. It has to be the basic thing that you have to do: identify tension pneumothorax, put in a needle thoracocentesis, or you put in a chest tube. Placement of the chest tube will take care of 90% of your thoracic injuries. So the management of thoracic injuries is very, very simple. It's putting in of a definitive chest tube. So you subject the patient to primary survey. What all do you identify? You identify airway. Air movement, the presence of stridor will give you a clue as to whether there is any injury in the trachea, the tracheobronchial tree or the larynx. You inspect the oropharynx for the presence of a foreign body. You look at intercostal muscle and the supraclavicular muscular retractions, which will give you a clue as to whether the patient, will give you a clue as to whether the patient is in respiratory distress or not, and laryngeal injury also has to be identified. In the breathing, you expose the patient's chest and neck. You assess the breathing of the patient and the neck veins. We have to follow the simple protocol that we've been following since we came into our MBBS. Your inspection, palpation, percussion and auscultation has to be done of the chest, and thus you have to identify injuries. You focus on the respiratory rate, you focus on the breathing pattern, you focus on the chest movement, you inspect, you palpate, you percuss for any, you have to see the note of resonance, you auscultate for presence of breath sounds, compare the breath sounds of both the sides. Cyanosis is a late sign, you do not wait for it, but if it is there, then you are definite that there is some problem in oxygenation and hypoxia is occurring in the patient. So injuries that should be identified and addressed in the primary survey are tension pneumothorax, open pneumothorax, a flail chest with pulmonary contusion and a massive hemothorax. We'll talk about these injuries individually. We've discussed them before as well in the first lecture, but a little more detail about the identification and management of these injuries. So what is a tension pneumothorax? A tension pneumothorax is a one-way valve air leak that develops from the lung or the chest wall. So what happens is, during inspiration, air will enter into the pleural cavity, but during expiration, this air has no means of escape. So with every inspiration, there is collection of air, ongoing collection of air in the pleural space, which increases the thoracic pressure, intrathoracic pressure, and pressure in the affected pleural cavity. This will cause collapse of the ipsilateral lung, the lung that is affected, which will displace the mediastinum to the opposite side. It can also collapse the opposite lung. So you have a huge problem in oxygenation and gas exchange. It will compress the heart, it will compress the trachea, it will compress the mediastinum. So increased intrathoracic pressure, which will decrease venous return. So what will you know this pathophysiology, so you can understand what the signs and symptoms of the patient will be. Both lungs collapse, the patient will be in respiratory distress, there will be hypoxia. Heart is compressed, the increased intrathoracic pressure is there, so there is increased jugular venous pressure, the venous return is decreased, patient will be in shock. So mediastinum is displaced to the opposite side, decreasing venous return and compressing the opposite lung as well. Shock results due to marked decrease in venous return, leading to decreased cardiac output. This is obstructive shock. So in shock, we've learned that patient in hypotension and trauma, we assume that the patient has hemorrhagic shock, provided the causes of obstructive shock have been ruled out in the previous steps. So you reach C after you reach A and B. So A and B, the steps in A and B will identify causes of obstructive shock. What are they? Obstructive shock in trauma is due to tension pneumothorax, and cardiac tamponade. Both of these conditions decrease venous return, leading to decreased cardiac output and cause hypotension. So these two conditions have to be tackled before you label that the patient has hemorrhagic shock. And these two conditions have to be tackled in the B part only. So that is why before you label the patient as having hemorrhagic shock, you have to identify and treat tension pneumothorax and cardiac tamponade.